A very good evening to one and all. On behalf of Neurocritical Care Society of India, I would like to invite all of you for the NCSI panel discussion today, which is multi-organ support conflicts in Neuro-ICU. The panelists with us today are Dr. Poneya sir, Dr. Sadiq sir, Dr. Shweta ma'am, Dr. Amarja ma'am, and Dr. Sindhu and me will be moderating this session. So when we talk about the brain is always dependent on other organs and other organs are dependent on the brain. And as an intensivist, there is always a conflict based on targets on which organ to choose and how do we reset the goals. So the format for this panel we'll be taking through cases, how the patient evolves over time and what are the complex decisions which we need to take to ensure brain and organ protection. So the first case, this is a 58-year-old woman with aneurysmal SAH. Patient has a GCS of 13/15. Patient is intubated, ventilated. MAP is about 60. An ABG done shows a lactate of 3.2. And patient is presently on NORAD infusion. And this is the CT scan. So patient in the ICU, it is day 2 of ictus. So Shweta ma'am, the first question is to you. So considering these factors, how do we proceed on determining what should be the map for this patient?
So this patient definitely has a bad grade SAH, and you said the patient is already in day 2. Is the aneurysm secured?
No, ma'am, the aneurysm is not yet secured, so patient is just presented to the ICU.
Okay, thanks. So you can see that the patient is intubated, ventilated, FiO2 requirement is slightly high, MAP is about 60, lactate is high, and NORAD is a reasonable dose of NORAD. So since it's day 2, aneurysm is not secured, our main worry is the main risk right now is that we are worried about is re-rupture of the aneurysm, right, which can be very detrimental to the patient. So in this particular case, the initial hemodynamic target right now, because the GCS is 13/15 as well, the patient is a little dull. So the MAP target I would keep would be a normal MAP target, which is like MAP 70. I will not go above that. And to achieve that, because the MAP is slightly low, lactate is high, I would check the hydration status of the patient by checking the skin turgor, the mucosa, and see if the patient is having tachycardia and unexplained tachycardia, and see the IVC, to do a poker, see the IVC, see the lung, see if the collapsibility index of the IVC, what's the size of the IVC, see the LV contractility, and if the other LV having kissing ventricles, then which clearly kind of shows us that the patient is dehydrated. So then I would give fluids. And since it's day 2, right now we're not worried about vasospasm as well, so I don't need to increase the MAP to any higher targets as well. So I would give fluids and then adjust the vasopressors to maintain a MAP.
So in day 1, when a patient presents when an aneurysm is not secured, so it's important to kind of do a multimodal assessment to understand whether fluid requirement is there and then target a MAP based on whether aneurysm is secured or not. So we proceed on day 2. We see that the patient is desaturating and PF ratios are becoming worse. And this is the chest X-ray picture. Sadiq sir, so what is your thought process and what would be your ventilation strategy in this patient?
So as you mentioned that the patient is having deteriorating PF ratios and her chest X-ray done, it is showing the bilateral homogeneous opposites. If you go by the differential diagnosis, there are multiple differential diagnoses. But just at the bedside, if we can find out the decreased compliance and the increased plateau pressures, then we can thought of that this could be a case of ARDS, acute lung injury or ARDS, depending upon the PF ratios. So there are certain strategies which have been shown to improve the mortality, improve the survival in patients with ARDS, irrespective of the subcategories. And one of the most important category means intervention is the adequate ventilation, that is known as the lung protective ventilatory strategy. So the component of the lung protective ventilatory strategies includes low tidal volume, that is 4 to 5 ml per kg of the predicted body weight. The target means addressing the plateau pressures and keeping it less than 30 centimeter of water as much as possible. And the other thing is the application of the high PEEP. So out of these three component, the PEEP is the one thing which means a dual effect on both the things. Means if it has a beneficial effect in patients with ARDS, but in patients with ARDS having an existing intracranial pathologies, it can adversely affect the intracerebral physiology. Whenever we apply the is going to increase your interthoracic, and the increased interthoracic pressure will leads to compromised venous drainage from the upper part of the body. So when this venous drainage will be compromised, the intracerebral blood volume will increase, and that will leads to increase in the intracranial pressures. That consequently leads to the decrease in the cerebral perfusion pressure. So this particular means interaction between the heart and the brain becomes very important while we are applying the PEEP. So in different strategies, it has been shown that a PEEP up to a 15 millimeter of mercury is not going to adversely affect the CPP uh, until means uh, we need to see the oxygenation target also. So if the oxygenation target in the normal patients with ARDS, we keep the target between 50 to 60 millimeter of mercury for the PaO2. But in patients with acute brain injury or in patients with SAH or compromised intracranial physiology, we need to keep the oxygenation target at the higher side between 80 to 90 millimeter of mercury. Similarly,
So
the
it
PaCO2 also.
Yeah. So,
Sorry.
sir, so what you are putting forward is in a patient with brain injury, we need to maintain good oxygenation target. At the same time, the ventilator strategy should not increase our ICP2. So that would be
Yes.
the take in this case. So the question to Amarja ma'am is, in a setting of SAH and a low oxygenation status, what else should we think about, and how would you go about this case?
So, looking at this situation, day two of SH, and when we are seeing worsening oxygenation, already neurological insult has happened, and that is leading to lung injury. So, primarily, it is not lung pathology causing worsening oxygenation. So, that we have to understand. Possibly, the differential I would consider in this situation is neurogenic pulmonary edema and catecholamine surge. That could be first differential. And in this situation, maintaining adequate MAP or optimum MAP, rather, it will be useful in order to avoid worsening oxygenation. Probably the oxygenation is worsening because of increased hydrostatic pressure and increased filtration that is causing pulmonary edema. So when in order to improve this patient's condition at the bedside, so how I will set the ventilator. So one thing is, if we look at the PF ratios alone, we may not find out what are the other causes for low PF ratio. So usually it is understood like low PF ratio is equal to ARDS. Probably not. One of the subset when PF ratio is very low and there are underlying lung pathologies. See, I can give you three different reasons where PF ratio can be low, like patient who is having embolism or pneumothorax and patient who is having pneumonia that is causing low PF ratio. So unless we identify the cause or etiology for the worsening PF ratio, our management will differ in all these settings. So looking at this situation, when I'm going to set the PEEP, why the PEEP is necessary is in order to improve the oxygenation of the patient. So that is the first thing. When I maintain the oxygenation, indirectly I'm preventing the secondary brain injury. And when I'm doing that, how much PEEP is optimum or safe for the brain? In this situation, up to 15 is shown to be safer. However, in each patient may respond differently to a set level of PEEP. So whether PEEP is causing any hemodynamic insult, so that itself tells that it is not a optimum or safe PEEP for the patient.
So in this
However,
setting,
yeah,
ma'am, like as Sadiq
yes,
sir said, and
correct,
you are
yeah,
also emphasizing that a lung protective strategy and P. But
yeah,
in a setting of SAH, and you have a
yes,
neurogenic pulmonary edema, So
Correct.
should our focus be on the lung per se, because we need to prevent secondary brain injury, we need to maintain oxygenation, that is correct. But to
Yes.
prevent worsening of oxygenation, the brain can be addressed. So in that way, will we add any other intervention at this stage to improve oxygenation apart from lung protective strategy?
So, first, suppose worsening oxygenation, you have set the low tidal volume. I will be careful. I will look at the PCO2, whether it is increasing PCO2, that also can cause rise in the ICP. And in this situation, whether the neurological problem can be tackled or should I worry about oxygenation? So, suppose oxygenation is a major concern. PEEP is the initial strategy I would like to use at the bedside. The next
Okay.
thing is whether I can use proning in this situation. That is again a dilemma. Okay, so whether I will be comfortable in proning this patient and whether ICP can be monitored properly, whether by
Because
using
let's
PCD
remember
or
that this is an unsecured aneurysm, and
yes,
still ICP component is not under control. So Punya
yes.
sir, what is your take on now oxygenations are worsening? That is the scan, and lactates are high.
I just wondering what you guys are talking on day 2. On day 1 itself, we would have planned for a clipping or coiling of the aneurysm. Okay, the aneurysm is unsecure. We don't get much time in these patients like day 1, day 2, day 3 to optimize. Okay, an aneurysm is there and it has to be secured. The maximum we get is about say 6 to 12 hours time to optimize the patient. So in the first slide itself, I would like to ask you what was the echo of the patient. Okay,
Okay.
because both
So
is
this was the echo
oxygenation.
of the
Yeah.
So this was the
Okay.
echo of the patient. So there is a
Right.
stunned myocardium. Troponins are high, and
All
that
right.
continues to day
So
3. So, yeah.
So the thing is that on day 1 itself, I will not even go to day 2. On day 1, on the time of admission itself, you know that there is a problem with the breathing, probably a pulmonary edema or ARDS, and there is also a problem with the circulation. And whatever strategy you are employing is not matching the perfusion, means you're not able to maintain the perfusion. So your strategy has to be optimized. You are asking about giving fluids or what else you will do. Of course, we need to have an echo finding. The echo you said there is a low ejection fraction, probably a stunned myocardium or a stress cardiomyopathy. So in this status, if you're not able to achieve your optimal perfusion, then you have to change your strategy. You need to employ advanced hemodynamic monitoring, optimize the patient on day 1 itself. So usually in these cases, what's the age of the patient?
A patient is 58 years old. No
Okay,
known
comorbids.
comorbidity. No known
Comments.
comorbidity.
So usually that I can see some ventricles are also getting dilated in these cases. So probably for ICP you can very well manage with an EVD if you want, and even in the beginning itself, even before securing the aneurysm. But you have to optimize the patient, both the lung as well as the hemodynamics. The perfusion should be at least controllable in order to proceed with the surgery. So on day 2, obviously this patient will be posted for a surgery or for an intervention. So even before that, you need to optimize. You need to have a goal-directed therapy, either with a PICO monitoring or a echo-guided therapy. You need to guide your fluids. You need to guide your. You may be on a completely wrong vasopressor, not adrenaline, noradrenaline. You might have to change into dopamine or dobutamine. At that time, your SVV might change. You might have to give more fluids, and you need to achieve the optimal perfusion before shifting the patient to the operation theater. So this is a very common scenario and a frequent scenario which we encounter. And usually these cases stabilizes in 10 to 12 hours time for us to provide the anesthesia for surgery. And post clipping, the aneurysm is of course secured, and by that time you can employ the ICP also will be under control, probably with an EVD. So at that time your management is not going to much differ from any other regular patient.
So, Shweta ma'am, any comments on that? Because like all of us discussed now, here brain is central to it. So unless ICP is controlled and we try to move the patient towards securing the aneurysm, we are kind of restricted on what all strategies we can use for the heart and the lung.
Yes. So Yes, like protecting ventilation strategies, PEEP, high PEEP, to maintain the oxygenation, which will help us in improving the oxygenation. And like Dr. Punaya said, maybe we have to change the vasopressors that we are using, right? And a use of advanced hemodynamic monitoring. Other than that, maybe like while doing either a pico based or an eco based, see the ultrasound of the lungs as well. If you feel the lungs of it's a neurogenic pulmonary edema, or like with takotsubo's also, we may have patients having fluid in the lungs. We can administer diuretics to, let the fluid off the lungs, but provided you maintain the volumic status as well. So that is one thing that another thing that we can do, so which may
Sadiq,
improve the oxygenation and the ventilation.
Sadiq, sir, the question to you is like, when would you consider stress cardiomyopathy in this setting? Like, patient can have an MI, also can have a stress cardiomyopathy. So, when would you consider that in your differential diagnosis?
Yeah, definitely. So this patient, looking at the age of the patient, she is a 58-year-old female. So she is definitely could be a case of CAD also. But if you look at the echocardiography at the bedside, and if you could document the apical and the mid hypokinesia of the ventricle, and a compensatory in hyperkinetic basal segment of the left ventricle, then you should keep this stress cardiomyopathy into your mind, that yes, this could be a case of neurogenic stress myocardium. Then the other feature which could be found in both the cases, like either acute coronary syndrome or the stress cardiomyopathy, they are more or less similar. You will find the STT changes, the troponin and CPKMB may be raised in both the cases. This is only the coronary angiography which can differentiate between these two. But yes, the bedside ultrasonography, if this apical hypokinesia along with the hyperkinetic basal segment, this is a pathognomonic of the stress cardiomyopathy, and you can in a very few cases you have to go for CAG to rule out the CAD.
Amarja ma'am, the question is, how would you kind of choose the inotropes in the setting? Like Punya sir said, use of advanced monitoring definitely will help us understand what would what would be the right hit for this heart to optimize it. So how would you go about choosing the right inotrope in this case?
So this particular situation, I would like to use noradrenaline as a first choice. Okay. Apart from that, main target is to maintain the map. NORAD is the first choice in any type of shock, if you look at the evidence. And optimizing how much map to target is something we have to we have to decide based on the non-invasive monitoring. Like either we can use TCD to look at the cerebral flow and decide how much map target should be optimal. The advanced monitoring like PICO and all, if you ask me, I have not used. Mainly, if you look at echo and ultrasound, that is good enough to tell us whether oxygenation is improving and maintaining hemodynamics, along with non-invasive cerebral monitoring can help us in titrating the adequate map.
So what would be the second inotrope? Now NORAD has reached its limit and still we are not able to get the flows perfusion. So it brings us to the concept of flow pressure. Punya sir, so what would be your second choice of drug?
So
You're muted, sir.
See, in this scenario, first of all, I don't agree with the concept of going to day 3 at all, because by that time some decision would have been taken, okay, to secure the aneurysm. Here,
Let's assume aneurysm is secured, sir. Now,
yeah, okay.
yeah.
See, you are doing an echo or finding an abnormality, right? Okay. So in the setting of subarachnoid hemorrhage, I will not even think about doing a coronary angiogram all these times unless the enzymes are elevated too much and the patient is behaving very unstable. So in this situation, you start with noradrenaline, like Madam said, there's more evidence for noradrenaline. But when your perfusion is not maintained, when urine output is down or lactates are high, your CRT is not under control, then of course you should be thinking about advanced monitoring as the next step, not going for another inotropes which is going to provide you any solution. Suppose I work in a setup where I don't have access for advanced cardiac output monitoring like PICO and other things, then you might have to play with other inodilators like dopamine and dobutamine and see how your perfusion parameters are improving. Having said, in this scenario, especially in this scenario, where I have worked with PICO guided monitoring, within, say, trust me, within 12 to 12 hours, you'll be able to, if the patient come in the evening, within 12 hours, you'll be able to optimize the patient and get the patient ready for surgery. And in fact, you can see dynamically the status of the shock will change. From a state of a cardiogenic shock, it can go for hypovolemia, where you might have to fill the heart, and then it might go for a vasodilatory shock in a certain phase. So the dynamics of the shock will be completely changing as the time goes by. So it is very essential that these cases should be managed in a setup where advanced cardiac output monitoring is available for us to achieve the best possible outcome. Otherwise, you keep on adding noradrenaline, vasopressin, and your perfusion will not maintain, and ultimately the patient will get for cardiac arrest.
Okay, so it's important to identify what is the right drug for the patient by instituting a monitoring modality wherever possible. So this patient, as we are trying to optimize the
Excuse
lung,
me.
yes.
Just wanted to share
Your
one
experience.
of the conflict,
Yes.
one of the conflict basically regarding the noradrenaline as a drug of choice. The another school of thought for the stress cardiomyopathy in patient with SAS that it is mostly caused by the noradrenaline means catecholamine surge.
Search.
So the another school of thought says that we should go for a non-catecholamine inotropes for increasing the cardiac output or cardiac index. And for that, the milrinone is not, but yes, levosimendan has been put forward as a good choice.
Okay, again, so that decision, Sindhu, yes. Shweta ma'am, yes.
Yeah. So, but with like Dr. Sadiq was saying, milrinone, yes, it is a good inotrope. It causes vasodilatation as well. But milrinone, when you start in IV doses, it causes hypotension. So that's going to be detrimental to this particular patient. So, milrinone per se may not be the first choice to manage this particular patient. Yeah.
Yeah, so when it comes to hemodynamic management, again, it depends upon what is the vasomotor tone and what are the interactions in maintaining the heart and the brain axis. So like ma'am said, milrinone causes a lot of vasodilatation. So you would need noradrenaline to kind of start milrinone in the first place. And milrinone helps if the heart is on a different trajectory. And like Ponya sir said, this is where your multimodal monitoring and advanced monitoring will tell you what your SVR is, what is your peripheral vascular tone. So I think that will help us decide and
No, I
precisely
think Madhuri, we should not be confusing the students and audience. Okay, it's very clear. Nobody starts levosimendan as a first choice vasopressor or
yes.
inodilator. Nobody even start milrinone as a first choice vasopressor or inodilator. Here the problem is you have to start a drug. Noradrenaline is the gold standard drug, despite whatever the situation it is. Okay, and when that is not working, your perfusion is not okay, immediately you have to go for an advanced monitoring. If you don't have an advanced monitoring, refer to a center which has. In that way, you can prevent therefore what is happening to your patient, rise in creatinine, sodium, CRRT, all those stuffs. Okay.
Okay, sir. Yeah, so NORAD is the first line of choice, and we need to evaluate further to add the second line. So I'll move on to the next one. Suppose this patient develops an acute kidney injury, and we need to start CRRT. So Shweta ma'am, what's your experience been in dialysis in patients with SAH? How do we go about that?
So when to initiate CRRT in a neuro-ICU patient? So this particular patient, the issue that is happening is that the patient's EF is low, tachyphoos, the lung is full, we do have no oxygenation. And he's, like you said, it is day 4 already. So now we are kind of entering the vasospasm stage, right? So if if the good thing about doing a CRRT is that your ICP, there are very less fluid shifts which happen in these patients. So, very less fluctuations in the ICP as such will happen with the CRRT. When to initiate, like in this particular patient, because the urine output is dipping, creatinine is increasing, and I don't have a way to hydrate the patient as well. So I would like the toxins to be cleared out first, and so that the oxygenation, everything can be maintained. Or you have to wait for the hard indications like hyperkalemia or severe metabolic acidosis, and that's when we can initiate the CRRT in this particular patient.
Amarja ma'am, is there a difference between intermittent HT, CRRT, SLED in a patient with
Okay.
raised ICP? How would you go about that decision?
So if I'm looking at this patient's progression, he has come with neurological insult, he had worsening shock, and now it is causing new organ failure, like in the form of renal failure. So in all this improving hemodynamics and improving acid-base balance, we are only treating the effect. We are not address the cause. That we have to understand. So the indications for doing whether should we go for different modalities like intermittent hemodialysis or CRRT and SLED, we have to look at what is the aim of initiating dialysis. Is it for rapid correction of acidosis, or is it for fluid removal, or we want to prevent fluid hemodynamic fluctuations during the renal replacement therapy. So if our primary goal is to maintain cerebral perfusion, avoid hemodynamic fluctuations, the best modality could be CRRT. However, looking at the centers who will have availability of CRRT, the SLED is a easily available option where we can have benefits of both, where rapid correction of acidosis can be achieved. However, if the situation comes like severe fluid overload, the fluid removal becomes a challenge, and continuing SLED for long time, like 8 hours, maximum 6 to 8 hours, we can run, and after that efficiency of filter will come down. So these are certain advantages when we look at SLED. CRRT 24 hours we can run, and when we look at which anticoagulation should I use, if you adjust the dose of effluent, if you give more effluent dose in pre-filter, probably you can avoid anticoagulation also in some subsets of patient where risk of bleeding is higher. So if I have to answer which modality, CRRT is the best. But if I have option of SLED, I will go for SLED. And also I
So
have to look
again,
at cost also is
the
important.
cost also is an important factor, and again we need to
Yes,
have our targets very clearly. What is the intention
yes.
of doing the dialysis, whether it's fluid removal, metabolic correction, and how much is the ICP? Okay, so what is going to have the maximum and the minimum effect on ICP? So what other monitoring modality will you use? Punya sir, what is your take on dialysis in a patient with brain injury?
So if you're talking about this particular case, it's straightforward here. The ICP is not going to be a major issue on day 4, and all. By the we might have handled the ICP. So if you're talking in general about brain injury, in my practice, we don't differentiate between a patient without brain injury and brain injury. It all depends on the hemodynamics of the patient and the state of shock which the patient is in. The patient is in shock, requiring more vasopressors, then obviously they will not tolerate the regular dialysis or even SLED for some cases. So we go for CRRT. If the patient is reasonably stable, then SLED. Otherwise, regular hemodialysis. Of course, CRRT has advantages when it comes to the equilibration, the shifting thing. But however, clinically, I don't think that it's going to make a major difference in the management of brain injury or the ICP. So it all depends on the situation, how the brain injury is and what stage of the brain injury the patient is in the ICU, whether it is early within 24 hours or the late phase of the injury in 1 week time or 2 week time. Based on that, you can take a call. For example, if the patient has got an acute kidney injury in a polytrauma with severe head injury, rhabdomyolysis, and because of that the kidney has failed, then that's a different scenario where CRRT may have a great advantage. But later in the course of the illness, on seventh day or eighth day, when things have settled down for the brain, when ICP is no more an issue, I think it's no way different from other
Managing
patients who doesn't have any other brain injuries. Yeah. So it depends
So
on the
now,
situation, the day of injury, everything. Yeah.
so in this setting now, if this patient develops vasospasm, so what would be your strategy in this case? Medical management versus intervention, because there is restriction on how much you can push the blood pressure in this case with a compromised heart, and the kidney is also compromised and the lung is also compromised. So how would you proceed in this situation?
See, again, it's already day 8. You have to reevaluate the system. Okay, you just recheck the heart, and you repeat the echo and see how the dynamics have changed. Okay, and vasospasm, the treatment is based on TCD of the patient. The patient is already intubated, so you don't know how clinically the vasospasm is worsening. The only thing which you are getting is the TCD vasospasm. So the TCD, if the patient is on vasospasm, of course you have to raise the blood pressure. Again, the same principles apply. Okay, so if the heart is weak and you want to get the blood pressure up, or you want to keep the cardiac output up, we could go for a cardiac output strategy. Like now the milrinone, everything will come in place. Okay, with noradrenaline to support the blood pressure, you can add on milrinone, which also helps in vasospasm. So in that way, you can achieve a target and maintain these cases. So it's all depend on the scenario. So in this scenario, I would use noradrenaline along with milrinone to raise the blood pressure as well as to augment the cardiac output to treat the vasospasm and see the response to that. Always, if you give a therapy, you see the response, whether the therapy is responding or not responding. One on the hemodynamic side, other thing on the vasospasm side in this particular case. So if it is responding, then you continue with that. If it is not responding, the patient is worsening, by imaging or any other means, you do an MRI and see there is a lot of DWI changes, ischemic changes, then you escalate to the next level. Take the patient to the cath lab, do a chemical angioplasty. You might have to repeat that again, and that's how we do that.
Shweta ma'am, your take on this? Inotrope choice any
So
different, or it's just NORAD, milrinone?
we would start with noradrenaline. Now, if the vasospasm is set in, then milrinone to maintain the MAP. And yes, continuous neurological monitoring is very important. Like you said, the patient is ventilated still, right? So probably a lighter sedation, very light sedation, where you can assess the neurological status as well of the patient and limb power also, to see if there is any new, deterioration in the patient which will warrant a need for taking the patient to the DSA lab and an intraarterial dilatation, if you have that facility. That
Yeah.
would be the thing. Yeah, because now vasospasm is playing a major role, and now slowly we are trying to do is prevent secondary brain damage. Yeah.
So the idea is to say that any organ dysfunction can happen at any stage, and we need to institute a multimodal monitoring and assess at each level to choose what is the right therapy at that stage. So I request Sindhu to proceed with case 2.
All right. So now we have a patient with traumatic brain injury with severe ARDS with a PF ratio of around 80. And his PEEP requirement keeps on increasing, and it has reached 14 to 16 centimeters of water. Now the ICP increases with the PEEP escalation. So now how do we set PEEP for a patient with a raised ICP? Basically, if the brain is also if the patient is having a severe TBI and the ICP is already elevated, and we've been talking that a PEEP up to 12 doesn't translate into a raised ICP, but now we are going to keep a PEEP of say 14 to 16. So how are we going to keep this PEEP for a patient with a brain injury with a raised ICP? Punaya sir.
So this is a quite common scenario, and the answer is also quite simple. First, you are addressing the breathing. You are saying it's day 2. I assume that it is a diffuse injury. We are not. There's no surgical lesion, so you're not intervened, and you're monitoring the ICP. And the patient is in ARDS. Already the PF ratio is 80. So by this time, ideally the patient should have been proned already. So any PF ratio less than 150, or some centers 200 itself, is an indication for proning, and the very good results we see with proning. So ideally at this situation, the patient should be proned and try to improve the oxygenation. So I would not buy the argument that the PEEP is raising the intracranial pressure. If you're monitoring the intracranial pressure and the intracranial pressure is 25, 30, 32, then I would not think that a PEEP of 12, maybe 14 or 18 in the maximum setting also is going to raise the intracranial pressure. In that situation, you need to address the cause of the intracranial pressure, whether the head injury is progressing, edema is progressing. In that scenario, whether you have to take up to the next tier of management. So all those things we have to see. Just blaming on PEEP, we cannot just keep quiet. So that would be my strategy. So in this patient, severe ARDS, a low PF ratio, increasing FiO2 requirement, the next strategy will be proning, neuromuscular blockade, and continuing the lung protective ventilation with a high FiO2 low PEEP strategy, which is the strategy which we follow even for a non-brain injured patient. It doesn't mean that necessarily the PEEP will be lower, but the titration is like high FiO2 and low PEEP strategy as per the ARDS net protocol.
Sadiq sir, how would you, how do you do proning for a patient with traumatic brain injury, which has not been surgically evacuated, and what all monitoring do you institute in these kind of patients? Sadiq sir?
Sorry, it was muted. So when we discuss the proning in patients with ARDS, so multiple studies like ProSeva, and they have shown the benefits of doing the proning session, and there was an absolute reduction in the mortality if we are following the proning session for more than 16 hours per day. But in patients who are having a risk of elevated ICP, or in which the cerebral auto-regulation is disrupted, the pruning can further means it's a challenging intervention in this subgroup of patients, because the during the pruning you need to decrease the head elevation. You have the intra-abdominal pressures are increased. There are compressions in the neck veins which can affect the cerebral venous drainage. So all of these things can adversely affect the intracranial pressure and cerebral auto-regulation. So while proning the patients, we need to take all these things and try to avoid the harm caused by the pruning position, and would take the benefits of the pruning position rather than the harm. So all these things have to be kept in mind. The head should be if we can keep the patients in the reverse standard position, like a head up position, straight head up. Also, the adequate padding should be done to that should be straight to reduce the compromise of the venous drainage. These all things have to be kept in mind.
All right, sir. So, suppose this patient has is developing a refractory hypoxemia, and we have employed already a proning, the proning maneuver. We also paralyzed the paralyzed this patient, and we have also done maximum basic ventilatory adjustments. So, the next step would be that should we consider an ECMO? ECMO in a patient in whom just the lungs are compromised itself is very challenging. Now, in this patient, there is also a brain injury. So, Amarja ma'am, could you please let us know how would you, when do you choose a patient with a brain injury for ECMO?
I think she's not here.
So then you can take up this question, sir.
Okay. So ECMO, of course, is now, as per the latest guidelines by both the ATS and the ESICM, It's been one of the approved therapy for severe ARDS patient in selected patients. So the selection criteria has to be met. First of all, the patient should not have any serious comorbidities or severe underlying lung diseases which cannot improve without transplantation. And the absolute contraindication is contraindication to anticoagulation, of course. And we have to see whether anticoagulation is contraindicated in the setting of brain injury which the patient has got. If there is a hemorrhage or there is a bleeding in the brain because of traumatic brain injury which is still unstable, and you think that radiologically it could progress or the hematoma could expand, of course, in those scenarios, we will not be able to give. We need to go with the conventional management. But on day 5, once the hematoma is stable, or you are thinking that there's no further increase in risk of hematoma, the patient is already on a DVT prophylaxis for prophylactic anticoagulation. Of course, in these patients, the indications will not differ from any normal patients. Still, you can consider for ECMO. However, we need to watch carefully the neurology, because as such also in ECMO, there is a risk of intracerebral hemorrhage when the patients can develop even without head injury. So with head injuries, we need to closely monitor the patient. The key is patient selection. Very young patient, you exhausted all your lung protective ventilation strategies, still you are not able to improve the oxygenation. The ARDS is very severe, the plateau pressure is too high, you are not able to achieve the plateau pressure without injuring the lung. Then maybe in those selected few cases you can consider ECMO. Also, you need to know that not as a last rescue effort you need to select ECMO. If at all you want to select ECMO, then as a decent time you need to choose. You need not choose after the patient develop multiple organ failure and the patient is almost crashing. Just for sake of rescue, you should be using ECMO. In those cases, the outcome will be really bad. So it's the selection of the patient and selection of the timing is very important. And as such, head injury is not an absolute contraindication to institute a patient on ECMO if he really qualifies for it, provided we can provide anticoagulation as well.
I think
Amarjam,
sorry.
yes, yes, Shweta, ma'am, please.
Can I? Yeah. So I think
Yeah, just wanted to
paralyzing
add.
the patient, what the neurological status of the patient also carries weightage as to, whether you should put all that resources, financial resources, and put the patient on ECMO as well. If it's a diffuse injury with a grade 3 DAI, patient does M2 or M3 even before you paralyze and prone, probably then you have to think twice before putting the patient on ECMO.
Yeah, the patient selection is very important. Yeah.
Yes, Dr. Sadik, you were telling something.
I just wanted to highlight the same point that before instituting the ECMO, we have to, but means it's already day 5. So by this time, the neuroprognostication has already been done for the patients.
Yes.
And
It should
if
not be a futile approach.
the neurological outcome is favorable, then we should not keep this ECMO in our armamentarium.
Correct. Yes, very true. Amarja, ma'am, you are there? Okay.
See, I like to slightly differ. In day 5, it's too early to prognosticate in a head injury patient. If we can do that now, then it's very easy. Our life is very, very easy. We can never prognosticate on day 5. Okay. So very devastating cases, we know nobody is going to offer ECMO for those patients. But in this case, you're monitoring the ICP already day 5. The ICP issues must have been controlled. So even if it is diffuse axonal injury, on day 5 itself, it will not get manifested in the MRI also. So for MRI also, this patient, you cannot shift the patient to MRI to quantify your prognosis. Okay, so it is very difficult to quantify the prognosis on day 5 itself, and practically it is not possible. So it is a very dilemma situation. If the patient is really young and you assess the other comorbidities and the severity of the injury per the CT scan, and if the patient has a chance of good survival, then still we need to offer them the ECMO. By prognostication on day 5, I would not agree, because it's very difficult to prognosticate a head injury patient who has done reasonably well till day 5. The long-term prognosis is very difficult unless the radiology is really, really bad.
All right, sir. Matangi, next slide. So now we have a patient with persistent fever, hypotension. The patient is having a rising vasopressor needs, worsening oxygenation, and a progressing acute kidney injury. So in a patient with, say this patient is a traumatic brain injury patient. So what would be your temperature target in these subset of patients, Shweta ma'am?
So, in acute brain injury with a patient, with persistent fever, hypotension, initially, yes, like as per the SIBICC guidelines, which includes temperature management in tier 1 and tier 2 as well. The ICP tier therapy as well. It's in tier 1 and tier 2, you maintain a normothermia 36 to 37.5 degree Celsius, and you do not allow the patient to have fever, right? Because it is quite detrimental to the cerebral dynamics when the patient has fever. So you actively control the fever. Like in this, it's written that the patient is having persistent fever. So you actively control the temperatures, and either with regular antipyretics. In our setup, we do use a low dose diclofenac sodium infusion to control the fever, hydration, and cooling maneuvers. And even with that, if the temperature, if the ICP, with an ICP monitor in place, if you feel the ICP is also rising, the tier 1, tier 2 you do, and then if it's going towards a tier 3, ICP is not being maintained with tier 1, tier 2, then your temperatures should be reduced to less than or equal to 36. In tier 3 therapy, as per SIBICC guidelines, it is said that even before decompressive craniectomy, you should consider,
Right.
you should attempt to reduce the temperature less than 36. Yeah.
Yes, ma'am. Amarja ma'am, so how does a sepsis alter the cerebral perfusion pressure and the MAP targets in patients with brain injury? Yes, ma'am, there or not. She's going. Okay, so sir, can you please take that question? How does sepsis alter the cerebral perfusion pressure and the MAP targets?
Of course, when sepsis, when it causes septic shock, we need to address that as implement all the sepsis bundle, maintain adequate map, and then you need to monitor the patient neurologically and take a call. So it's already day 6, day 7. When the patient develops fever, sepsis should be your not only fever. Along with that, you said AK is developing, is having renal failure, when there is organ dysfunction, and of course it qualifies for a sepsis, and you need to implement the sepsis bundle, antibiotics, fluids, and measuring the perfusion. So all those things should take priority. And then next, you see the effect of that. Whatever you're doing, your management, whether it is responding, with the perfusion is improving, then you check the cerebral hemodynamics, whether it is getting reciprocated to that, and then you carry on with the sepsis management.
Yes, sir. Shweta ma'am, if I could ask you, how will we differentiate infectious from a central fever?
Sorry?
How can we differentiate an infectious from a central fever? Do you do any
Okay.
biomarkers to
So this is
better to?
something that we face in our ICU very often: central fever with an infectious fever. So clinically, if you see, the fever can be very, very high. It can go up to 102, 103 as well in a central fever, associated with, yes, systemic effects like tachycardia, tachypnea. Patient may not have hypotension like in an infectious fever. And it could be in a central fever, it will be very persistent, continuous fever. There will be very less fever free periods compared to infectious fevers. And of course, the TLC, Procal, CRP is something which we can check, which, a Procal will give you the value within like 2 hours. You'll get the value and you'll know whether, if the Procal is raised, then definitely it is an infectious fever. If not, it could be a central fever. Another thing is probably if in a traumatic brain injury, you do deal with patients with PSH, paroxysmal sympathetic hyperactivity. So in those patients also fever can occur. At that time, you see if there's tachycardia, tachypnea, posturing, abnormal posturing of the patient along with fever, then that kind of points towards central fever. Sorry.
No, can I add a point?
Yes, sir.
Yes.
Please.
So the thing is that we need to change our approach in seeing these patients. We should not see as temperature. We approach the patient as whether this patient is in sepsis, not in sepsis, whether there is an organ dysfunction, dysregulated host response or not. We are not going to give antibiotics for fever, right? But if the patient is in sepsis, irrespective of whether the patient's temperature is high or low, we are going to give antibiotics. So that's the difference. In both the cases, we are going to control the temperature, be it is central fever or whether it is due to sepsis. We need to have aggressive measures to control the temperature. But can we achieve the temperature control optimally in all the patients? Even the best of the best ICUs will struggle to get an optimal temperature for these patients, even though we very well know that temperature control is very important in neurocritical care patient. But with the available medications and available strategies, if you ask 5 intensivists, they'll be giving 5 ways to how they control the temperature. They'll be using low dose Dynapar infusion. Somebody will be using surface cooling. Somebody will be using fans to control the temperature, which I may not like it because that causes shivering. And the best way to control the temperature, perfect temperature, is only by intravenous cooling device. You set the temperature 36, the temperature is going to be 36 for the patient. But it's possible in all the patient? No, it is not possible. So the way to approach this patient is not as fever is central or septic or the infectious causes. You need to see whether the patient is in sepsis or not in sepsis. And it's not only by the criteria and the Muse2 criteria you diagnose the patient as sepsis. It's also important that we know that we have our community itself have struggled to define sepsis over a long period of time. So it's also the experience of the practitioner which matters to identify a sepsis and implement the bundles at an earlier phase, which also has high mortality. And of course, central fever, when it is uncontrolled, also has very high mortality. Even if central fever is associated with hypotension, obviously the patient will be getting antibiotics, because when there is an organ dysfunction, we cannot compromise on our therapies. We need to employ the therapies in the forefront, because we don't know what is going to happen. When the patient is sick, then we employ all the weapons which you have got. But when the patient is not sick, only fever, then you manage the fever alone.
Correct, sir. Thank you for that, sir. Matangi, yeah. Now we have a 70-year-old woman. She has a large lobar right-sided ICH with a midline shift. She's a known case of atrial fibrillation. She has a prosthetic mitral valve, and she recently has her NSTEMI. So because there is an ICH, definitely we have to stop the anticoagulation. We have to reverse the anticoagulation. But now, when do we start the antithrombotics for this patient? Because she is having a prosthetic mitral valve, and if you do not start it, the valve is at risk. So, Shweta ma'am, like, how do you risk stratify the timing of anticoagulation resumption in this patient in this context?
Always a controversy, right? So, so the risk, what are the risks in this particular patient with ICH? Yes, this looks like a very large bleed, right? So what are the risks? How do we decide? So the main thing what we need to see if is the main worry about in this particular patient with AF, a prosthetic mitral valve, and a recent NSTEMI is having cardiac complication, like if she can have stuck valves, thromboembolic phenomenon. So you should kind of balance out which is decide which is more risky for her? Whether, it is risky to have the ICH increasing in size, or whether it is more risky to have, thromboembolic phenomenon. So one thing to do is, like, if it's a small, whether the bleed is big or small, there is no specific size which is like mentioned. So if it's a very small bleed, then you can still probably, with all the risk explained, you can still start the anticoagulation in less than 2 weeks time. But if it's a large bleed, you may have to wait slightly longer. While doing this, you should assess the risk of the patient developing a thromboembolic phenomenon with the CHADS2 VAS score. So with that, you should be able to assess the risk of whether the patient is at a high risk of developing thromboembolic phenomenon, see the Well score. So these are few things that you can do to assess.
Matanki, can you just put on that next slide? So could you just please explain this, the timing of resumption? We can't hear you, sir.
Okay. See, it all depends upon the pathology, whether it is an ICH, whether it is due to trauma, or whether it is a spontaneous SDH or a recurrent SCH and amyloid angiopathy. And the indication for anticoagulation, whether it is due to atrial fibrillation, you want to initiate anticoagulation, or due to a mechanical heart valve, or for venous thromboembolism or deep vein the DVT treatment. See, you all know that for DVT prophylaxis, so once you monitor this patient, especially in traumatic brain injury, when they radiologically, when the hematoma, the contusions are stable, you can start DVT prophylaxis as early as 24 to 48 hours time. So for prophylactic low molecular weight heparin for DVT prophylaxis, even in ICH patients, when the radiologically the bleeding is stable, you can start earlier if the patient has got very high risk of DVT. The patient is at a very low risk, then probably we can wait for 1 week also, right? But it's safe to start. But when it comes to therapeutic anticoagulation, like in the case which you described for a valvular heart disease, they are at very high risk if you don't start, if you delay the anticoagulation beyond 2 weeks. Okay. In the initial phase, I assume that you might have even reversed the anticoagulation.
Yes.
When the patient is presented with a vitamin K antagonist, you must have given PTCC, vitamin K. So you might have reversed the anticoagulation, brought down the INR to normal. So you don't have much time to resume the anticoagulation. So when the clot is stable, probably if it is a huge clot, obviously the patient will go for a surgical evacuation. If it is a small clot, managed conservatively. In any scenario, I would start, if it is a valvular disease, if a prosthetic valve is there, then at around 2 weeks time, you have to start therapeutic anticoagulation. But if it is atrial fibrillation, even high risk atrial fibrillation like the Charles, you can wait till up to 4 weeks also, not a problem. Okay. For secondary prevention, in other cases, you can wait even much longer. But if it is a recurrent ICH, the patient has already developed two ICH. We ourselves have seen some cases where they come with an ICH at different locations. Of course, for them, the bleeding risk is very, very high, so we need to wait longer. If it is an atrial fibrillation where you cannot start anticoagulation, then you have an option, alternative options to anticoagulation. Like you can go for a LA appendage closure, AF ablation, all those things could be considered. So these are all the ways we can optimize the resuming the anticoagulation strategies after a hemorrhagic issue in the brain. And remember that spontaneous subdural hematomas, so they are also at very high risk. The patients coming with spontaneous subdural hematoma, especially for anticoagulation, we might have to wait at least 1.5 months to resume the anticoagulation if they have atrial fibrillation or if they have a mechanical heart valve, because they can recollect very quickly. Of course, now we have an option for them, we can even embolize the patient. MMA embolization can be done the early phase itself, so that we can resume the anticoagulation a bit earlier. So these are all the ways we need to, strategize and optimize our patient.
Thank you, sir. Thank you so much for the lucid explanation. So it is the same thing, Matangi. It's what we discussed earlier. So with this, I think we have discussed all the, acute brain injury and its effect on the other organ systems and how to manage that. So recently also one study a trial had come, that is the ProLabi trial. So that was whether lung protective ventilation is useful in acute brain injury patients, and they found that actually the ARDS net protocol, the lung protective ventilation actually does not improve the mortality in the subset of patients. But sadly, they could not complete the study because of funding problem. But they, out of the 500 patients, the 200 patients, whatever they had evaluated, they found that the mortality was actually worse with lung protective ventilation. So yeah, I mean, we need more studies in our subset of population to actually conclude what kind of ventilation strategy we are supposed to follow in brain injured patients. Martin, do you want
See,
to?
In that
There are
trial,
few.
they've given plateau pressure if you maintain in the ProLabi trial, what you're talking about.
Yes,
They
ma'am.
have given, usually we keep plateau pressures less than 30. So in this particular trial, they have mentioned that plateau pressure, if you keep it less than 27 centimeters of water in TBI, that is shown to uh, have some effect in the outcome and reduce the mortality.
Yes,
So
ma'am.
that's like usually we do less than 30. Then this is one thing that they have said, less than 27 if you keep the plateau pressure.
Yes, so you were
There are.
telling something.
Yes, sir.
yeah, see, I think with this one study, we cannot dramatically change our practice. Lung protective ventilation is the standard of care, even in non-injured lung, especially so in the injured lung. Of course, we have to monitor the plateau pressure. Even more specific, you can measure the driving
Driving.
pressure to
Yes.
titrate our strategy. It's not necessarily that all the patient you have to start with 6 ml per kg. You can even start with 8 ml per kg. And also, we need to remember that it's the ideal body weight, not the actual body weight, based on which we titrate it. I think that will be the standard as of now, unless something drastically changes. And this has been used for years, and so many patients have been benefited with this strategy. I don't think in near future it is going to dramatically change. Maybe the targets which we set, like the plateau pressure targets, the driving pressure target, and more and more employing monitoring to prevent aggravation of lung injury, might be helpful in these patients.
I think the main thing is while managing these such patients like with ARDS and traumatic brain injury or SAH, the main thing is any change in the ventilatory settings that you do, you go back and check your plateau pressure, check your driving pressure, and see how it is, whether it is improving, not improving. If you have like if you're having to increase the PEEP, if you have an invasive ICP monitor then you check if that is causing any changes in the ICP, check your hemodynamics. So, you can't just go by the numbers. You have to just do a total monitoring of all the systems that has an interplay in each patient.
There are
Over to you.
two questions in the comment box. One is this: how to manage isolated sinus tachycardia in adult TBI where temperature, sedation, shock has been ruled out? So, Shweta ma'am, any take on? So, the situation of isolated sinus tachycardia, again, it depends on the type of injury and what was the day of
Yeah.
presentation. And
Yes.
we did discuss about central fever and paroxysmal sympathetic hyperactivity. So, the
But in this,
diagnosis
it's
can
written
be
temperature, everything is ruled out.
normal. Yeah,
So
normal.
probably I would just like to give a very, very low dose of an IV beta blocker and just see what the change is, and meanwhile reassess everything again. You know.
Propranolol also, Propranolol
Yeah.
can also be a good choice over here too. If it's a sinus tachycardia, I mean, that'll be a
Yes,
good
if it
choice.
is a sinus tachycardia.
That's the
Yes.
only drug which have been proved to improve the outcome in TBI patient.
Outcomes. There's one more question of role of extracorporeal carbon dioxide removal in case of TBI with ARDS.
Yeah, very good question. Actually, now that we have got this system available in India, so that is the first thing which I need to tell. But I have not used it yet. I've not got the opportunity to use it yet, and I don't know. With my experience, I cannot say anything. But yes, it is a useful armatorium. If at all you are in a situation, you can use that because we have the device available right now in India. And hypercarbia, not in all the cases, it's going to increase your cerebral blood flow or cerebral blood volume. And if you have a point of care monitoring like a TCD, you can see whether your hypercarbia is actually affecting your brain circulation. It is generally said that if you increase the CO2 hypercarbia, then your vasodilatation will happen, cerebral blood flow will increase. But with the help of TCD, you can actually see what is happening. So if that is the case, if it is a hyperemic circulation, of course you need to control your carbon dioxide levels, and for that, if I have not landed up in the situation where I'm not able to, control my CO2 levels, but you are in a situation like that, then of course you can use this. But again, anticoagulation, other things also you need to take a look whether the system needs heparin or heparin free, whether you can do. And the system is available, of course you can go for that. It's an armatorium, it is a device. Whenever you want it, you can use it if the situation warrants it.
The last question is any
But in
role for
majority of
liver?
cases, sorry.
Yes, sir, Sadiq, sir. Yes.
Yeah, so in majority of the cases with ARDS, hypercarbia is mostly not an issue. It is an hypoxemia, which is going to kill the patient. Hypercarbia is not. Secondarily, the role of the tissue oximetry. So if we are instituting the tissue oximetry and we are targeting the brain oxygenation, so the raised PSU2 level is not going to affect the cerebral physiology. But yes, I agree with this, sir, that the devices are available, and if required, it can be used. And regarding the anticoagulation, they are very low flow devices, and usually they can be continued without anticoagulation.
No, I
And
didn't say that CO2 is not going to affect the cerebral hemodynamics. Thing is that you have got point of care device to assess the cerebral circulation. It can affect it. Theoretically, it can affect. You raise a CO2, we have seen hypercarbia, it increases cerebral blood flow, cerebral blood volume, it can cause brain bulge, all those things. So it has a very tremendous effect on the brain if the brain CO2 reactivity is too good. So we cannot just say that we can accept hypercarbia in an acute situation of brain injury, especially in the first few days. So that is a concern. That is really a concern. We need to maintain normocarbia, and if that is not possible, if it is not a brain injury patient, whatever you are saying is correct. Maybe you can accept permissive hypercapnia up to 60 also. You can accept that cerebral vasodilatation, which happens, but not in a case of traumatic brain injury when the patient is acutely brain injured. And this can save the effects of hypercarbia, but provided the case selection should be there, and the ARDS should be so severe that you are not able to maintain oxygenation without hypercarbia.
so one more question in the chat box is any role for ivabradin in the neurointensive care unit? Is there any setting where you would prefer using ivabradin for sinus tachycardia, for example?
No, mostly by the cardiologist, it is used a lot for ischemic
They love
cardiac
evaporated.
indications. Yeah. So in our setting, mostly we use propranolol, and it gives the best results. Use it, not a problem. It's not going to cause any major harm.
And one last
Just
question
be
is
careful in using ivabradin in patients with AF. It may trigger AF. So, uh, if you're, don't start giving ivabradin in your AF in a under patient who has AF. And that just keep in mind.
So the last comment is, please tell how to take Lindegard ratio. So Lindegard ratio basically is to differentiate between whether the rise in flow in TCD which you're seeing is because of vasospasm or hyperemia. So you basically measure flows in your intracranial vessel and your carotid and look at the ratio between both to see whether it is hyperemia versus vasospasm. So that brings us to end of this panel with multi-organ conflict and conflicts which still has a lot of unanswered questions. But thank you to all our panelists to have this wonderful discussion, and of course to my moderator buddy, which is Sindhu. It was nice having all of you. Hope to see you soon in the next forum.
Thank
Thank you,
you.
ma'am.
Thank you
Thank you,
so
Sajid.
much.
Thank you. Thank you so
Bye,
much.
everyone.
Thank you.
Thank you.
Bye. Good night.